Okay, good evening and welcome to the second session of the first module on non-muscle invasive bladder cancer. My name is Hamad Athar. I'm Professor of Urology at Khan University in Karachi. And my two course coordinators, Mr. Zishan Aslam, who's again from Scotland, and Mr. Dr. Wajahat Aziz, who is an assistant professor at the Department of Urology at Khan. So course today, essentially, we have moved on from TURBT, which is the cornerstone in the diagnosis of bladder cancer. And we've talked about various ways of doing TURBT. We have talked about how to do it in difficult situation. And then we had a talk about risk stratification, which is the cornerstone in the management strategy for non-muscle invasive bladder cancer. Today, we are going to take up some very important areas. Number one will be Mr. Ghulam Mustafa Nandwani. You have had the pleasure of seeing his talk, listening to his talk the last module. Mr. Nandwani is a consultant urologist with a special interest in bladder cancer, works at Linewells Hospital in Scotland. Our second speaker is Mr. Zishanuddin. He's a histopathologist at Khan University, special interest in GU histopathology, and he has been marvelous in our understanding of the pathological aspects of urological cancer as part of our multidisciplinary tumor board. So Zishan, welcome on board for this presentation. Our third speaker today is Professor Iraklis Mitsogiannis. Iraklis is a professor of urology in School of Medicine in Athens, Greece. He also shared a great interest in bladder cancer. He will be the third to speak, and he'll be essentially talking about the follow-up. So I'll start with Mr. Nandwani, and he's going to talk about some of the special things that you can do while doing your diagnostic cystoscopy and TURBT, making the diagnosis of bladder cancer. So Mustafa, you can share your slides.
Okay. Okay, just a second. This is...
Hello, professors.
Hi, Prof.
Hi from Athens.
Yes, we just talked about you. So we have Mr. Nandwani from Scotland, Dr. Zishanuddin, who's our histopathologist, as the other faculty member. So welcome on board, and thank you very much for being here.
Thank you.
So the first talk is by Mr. Nandwani, who is going to talk about the diagnostic things in bladder cancer. Can you share your slides?
Okay, I can't see the what you call it, sharing things.
It's at the bottom, green bar showing up. Green
Just
arrow.
a second.
Or you can see it on the top as well.
Okay, just trying to see. So, okay, previously it was there. I don't know what has happened. I'll just open my things first. Second.
I think there's a bar at the bottom with a green arrow.
Oh, yeah, that's right.
Pointing
now I
up,
can see it. That's okay.
So great. We can see your slides. So
Can you see my slides now?
Yeah, we do. Just
Okay.
go on to presentation mode.
Okay. So, good evening to all. Assalamu alaikum and namaste who are listening to me. So I think we'll just move on quickly so you all know me. So first thing, I think regarding the diagnosis of the bladder cancer, so it's pretty you can say like in the last 20, 30 years, so it has not changed much. So whenever there is suspected bladder cancer, you do the cystoscopy, you find the bladder tumor, you do the TURBT, do the histology, staging, and the management. Then is there anything which has been added to the recent diagnosis, like urinary markers? Some improvements are done in the optical improvements, technological advances, which are led to clear, you can select procedural benefits. Some techniques have changed, the role of imaging and technology in the disease management as well. So we'll talk through bit by bit and then get what exactly we can do in the practical life. So initially with the urinary markers, this is for a long time, the urine cytology has been the part of the diagnostic workup. But however, the diagnostic yield for the low-grade cancers was low, and it was mainly seen that it's in high-grade bladder cancer, the role was. And then there was a thought it's too cumbersome, inter-observer bias was there. So there was a need for doing some markers so that we can rely more it's like in an accurate way in the diagnosis of bladder cancer, particularly for the low-risk group. Unfortunately, if you see the urinary markers, which are for the diagnosis, they have a low specificity, costly, and there are no significant randomized control trials. There are prospective studies. They say that there are negative predictive value is there. For the diagnosis, there is some list of the markers there. Molecular markers and surveillance, there is a Eurovision and other, which you can see, but again, there are studies are there, but these have not up to the mark where we can say that they are in the routine practice. Yes, these are being used, they can help, but they have not replaced the cystoscopy, because the idea was that if the urinary marker was there, can it replace the cystoscopy? But unfortunately not. And somehow in the surveillance cystoscopy combination of these markers, they have helped. Then there is an optical aids in the diagnosis of non-muscle invasive bladder cancer. The reason was that white light cystoscopies, it's like there was a thought that it's missing. That's why the recurrences are higher. Is there anything we can do to increase the yield? There are various type of optical aids you will see, but there are two particularly which I will talk about. They have been used in clinical practice more often. So first is the PDD of the diagnosis. So normally, if you see there's 5-alpha-livolanic acid, which is formed by the succinylcholine A and glycine in the normal cells. Then it is converted to protoporphyrin 9 in mitochondria. And the normal pathway is that this protoporphyrin 9 is converted to heme and bilirubin, and that's how it gets filtered. But in the cancer cells, that you can select the step where the protoporphyrin 9 is converting to heme, that is deficient. And that's why there is an accumulation in the cancer cells. And that's why this was the basis for the photodynamic diagnosis, where when this like a protoporphyrin 9 is a photoactive, and that emits the red light when it's seen by the blue light. So that's how the mechanism is. So blue light is given excitation, and the flare is the red, and which is seen on the cystoscopy, and that's how you know the hidden tumors. Now we'll see that does it really increase the diagnosis and how it helps us in the practical life. So if we see the randomized trial, which was done in 2007, there were 218 tumors, low grade, were found in 196 patients. So 95% were detected by PDD and 83% were detected by white light. So this in the same patients where they did the white light and the blue light. And this was statistically significant. However, if we come towards a slightly larger tumors or the T1, there was no significant difference, and false positive rate was 39%. So that's the main important message from this one. Second is that, again, there was another trial which look at more aspects of the tumor, and where they found there's a more yield for PA plus CIS tumors. and that was statistically significant. And the third trial, when they did it, which was in 2011, again, there was a more pickup rate in the PDD. The PDD was picking more CIS, and there was no difference in the TA. This trial also assessed the recurrence-free survival. However, this could not gain the benefit of recurrence-free survival with the PDD and the progression-free survival as well. So if we go more, you can say like PDD reduces the recurrences. So if we look at more studies later on, so there is no you can say like a significant recurrence-free survival benefit with the PDD. I'm not sure what's the reason, but secondly, it's costly as well. Could be the people are becoming more meticulous with the white light cystoscopy and they are doing different, they are spending time. That could be the reason. So I'm not sure why the results were like this. So that's on the right, you'll say that there was no significant difference. Another trial which was done for all risks in the non-muscle invasive bladder cancer slightly earlier, and that again failed to show any difference of recurrence-free survival. So, and this also looked at it like with the grade of the tumors, and again this was not significant, and then multiplicity of the tumors as well. So again, these were not helped in the reducing the recurrences. So in summary, the PDD increased the detection of small tumors and CIS. It has not shown any significant improvement in the recurrence-free survival. It's costlier than the white light and slightly time-consuming, but this is another tool where you can increase the detection rate. And in some studies, it says in around about 15% people, they actually change the management pattern based on the diagnosis. So that's one of the important things. Narrow band imaging, the principles are that the hemoglobin is when it's the blue lights, it absorbs the blue light at some wavelengths of 415 and green light at the 540 nanometer. And then once this is absorbed, this is like this emits a different light pattern, and that has been seen. So what exactly we are saying that the vessels around the tumor vessels, they becoming more obvious when the bending is applied to the light, and that's they become more visible. And this is like on the background of the dark green or black, and the tumor becomes this becomes more visible. So if we see the reviews, the narrow banding imaging that has a 96% sensitivity, specificity is 65%, and accuracy is 90%. And if we compare to the white light, the sensitivities and all figures were slightly higher. And in comparison to PDD, that's also nearly equal results. So if you see that there is a, you can say like role of narrow band imaging, slightly it's easier to use. And if we see some randomized trials, so again, it says the recurrence, you can say like 3 months recurrence periods with the white light and the narrowband imaging were less. So that was statistically significant, and it has shown that in the long run, it's 12 months recurrence-free survival was more, you can say like in a narrowband imaging. So that's how the results are. So in summary, narrowbanding imaging increases the detection of small tumors. Narrowband imaging does improve recurrence-free survival. This is not as complex as with the PDD, and simply to use by just changing the generator settings, which are already in the camera systems, if we have the specific ones. Secondly, in the advancement in the surgical techniques, because the reasons were whether we were getting more detrusor muscle, we need to prevent complications and bleeding or some other episodes which relate to the hospitalization. So that's why some techniques and the technology was developed. So if we see that standard technique, we all know transurethral resection is still the gold standard. It's a piecemeal type of resection, which is does. What were the problems? The obturator reflex, which leads to perforation, sometimes overactive bladder symptoms, difficulty in controlling the depth, particularly when there is a charring effect, and the histology parameters are lost, and which provides a more important factor in risk stratification and diagnosis of and further management. And other thing, the monopolar ones particularly, they require the current flowing through the patients as a circuit, and that can have some anesthetic and you can say like complications related to pacemakers. So that's why there was a need to see that is there any improvement can be done. So first, so if you see that what are the techniques which have developed, even if we see that there's a bipolar resection and the laser ablation tumors as well. So whatever the technique is, it can be done like a standard TURBT can be done by monopolar, bipolar, laser resections, and block resection that was developed for the small tumors so that you get a more, you can select precise histology. It can also be done by monopolar, bipolar, and lasers, and ablation of the tumors. This is mainly for outpatient surveillance cystoscopies or where we already have an aim that patients does not need a full resection to prevent comorbidities. So if we go through the, you can say like monopolar versus bipolar laser standard versus N block. So this is the table which I made from one of the randomized trial. So if you see that in it's like this area, so almost with each technology, they all have the same amount of detrusor muscle present. Surgery time is no different. Obturator reflex is almost same, except if you see the laser TURBT, there's almost none. However, the perforations have happened in the laser. I'm not sure, but it could be the technical factor, but we'll see the next slide will gain some more evidence on the laser. And so in summary, this has unfortunately not shown any significant difference in the pathological and intraoperative outcomes. So there are techniques which are still developing, but the message is meticulous TURBTs or N block resection, whichever technique you do, so that makes a difference. Laser resections, these are further developed, you can select to improve operative problems like obturator reflex, bladder perforation, and good quality of resection tissue, which has been shown in some studies, but there is some improvement. Post-operative outcomes like a catheterization and hospital stay. So we'll see in this next chart, if you see, there is in the laser and the TURBT group, there's a vast difference that there was no reflex, obturator reflex. Bladder perforations were almost less than, you can say like 0.5%. Blood loss was less. Overactive bladder symptoms were less. So these were significant. These comes in some reviews. And other thing like catheterization time and hospital stay times and detrusor muscle specimen, these improved from the laser resection. Possibly we are doing it more careful dissection, and laser does not cause more charring effect, and irrigation times were less. So with the lasers which have been used are NDA, holmium, green light laser. So these all have been used. So whichever you can select. So almost the data is same for each laser. Surveillance, this is, you can select, is a more, you can select important thing that how we are going to surveillance. So there is standards, the white light cystoscopy, but the local anesthetic procedures has been added. White light cystoscopy with the laser procedure and use of VDD in outpatient setting. So the reasons for these thoughts were because non-muscle invasive bladder cancer has a very high recurrence rate. Progression is slightly different, but recurrence rates in 5 years, you see around 50% approximately at average for 5 years. So that's why this intensive follow-up required. But whenever we find on the follow-up the recurrence, either they need the TURBT or cystodiathermy, and majority of the time we do it under general anesthetic. So that brings to the complications of the procedures itself. Can we minimize the procedure you can under anesthetic and reduce the complications, anesthetic risks, because the more time you'll do the general anesthetic, the more anesthetic complications, hospital stays, capitalization, and cost implication. So that's why the minimally invasive options, what were you can say are gaining popularity is the local anesthetic cystodiathermy, which is like urethral, which can be done by laser or standard diathermy as well. This is best for the small volume tumors, particularly in the high risk patients, and where the aim is to control the disease. And this has been seen that it's safe in the anticoagulant patients on the anticoagulants, where if you stop the anticoagulant, they may have some consequences due to it. And this is less costly because we are preventing a TURBT in some selected group of patients, and then it generates the more resources on the normal theta list for other complex patients. These are the all benefits. So if we see that Tula versus local anesthetic diathermy, so if you see what are the differences in the study, obviously there's no significant difference in the recurrences and progression. Slightly progression was higher, possibly they get the more high-risk patients. But if you see that emergency conversion to GA procedure was more higher in local anesthetic diathermy, and failure to proceed was higher. So that was slightly less in Tula. So this is like a, sorry. So this, you can say like the lasers, the only disadvantage is that they require some specific environment where the lasers can be utilized. Laser fiber, slightly cost is added, and we need the laser trained staff. However, in the local anesthetic diathermy, the standard equipment there, so there's no standard, there are no specified changes to the theater and staff is required. If we see the comparison of laser ablation with or without PDD, does it make any difference? So there was some study in 2013 which looked at it, and they found, yes, there is a recurrences are less when the PDD is used along with the laser, and it was cost effective in a sense that people were not getting sent to TURBT. So overall, there was a cost benefit of £538 in that study. So in summary, there is improvement in optical aids, which improves the detection, recurrence-free survival. Cost, time, and feasibility are issues, but we can sort it out, and it depends from hospital to hospital and availability. Techniques, laser, definitely it prevents the obturator reflex, because the conventional technique, no matter you do the full paralysis, the direct muscle stimulation will still happen. You have seen that in the open surgeries, when the open surgeries are done and there's a the abdominal muscles, when they are like diathermized, they get the twitches, so same phenomena happen. Bipolar is safe in pacemaker patients where it's required, and these techniques are used for ablation as well. Surveillance with local anesthetic procedure, this prevents the TURBT in high-risk patients, and this is gaining in popularity. And currently, the laser sizes are becoming smaller. So currently, for specifically Tula purposes, there are lasers which are carbon dioxide lasers, which are almost like a laptop bag size, and they can be plugged in with the normal plugs, and that's an advantage as compared to the bigger lasers. So this was there. I think here I will stop my talk, and I'm happy to take questions.
Right. Thank you, Mustafa, for covering up this important area about the new modalities, not really new, but these modalities in the diagnosis of non-muscle invasive or muscle invasive bladder cancer. What is the current status of optical coherence tomography, which used to be one of the modalities, but I don't think that you've talked about it. Is it still being used?
I mean, to be honest, I have not seen in my area, at least in Scotland and in the other areas where I have worked, because these are there. Usually, these are used as a part of the trials, but in the clinical application in as a routine practice, that is deficient uh, because of the cost training of the staff, and that's why I think these are deficient mostly. So.
The questions about how long do you keep a catheter? So an uncomplicated TURBT, do you do it in the, at least in NHS setting as a day procedure, or they are admitted overnight?
Yeah, so catheterization. So I think currently there is a shift to day case TURBT. So if you select your patients who are less than 3 centimeter, probably solitary, and they have no significant less. So mostly, if you do early on the list, they can be sent home. And mostly, our average catheterization time duration, regardless of whether we do day case or like an inpatient, is around about 1.5 to 2 days, not more than that. The so I think I would say 1/3 of the patients, they can have their catheter removed on the day of operation. We keep them in because in the Scotland, what is happening, the patients come from slightly farther distances. So from the logistic point of view, we keep them in and then let them go home tomorrow morning. So that's exactly not the day case, but sort of a 23-hour. That's a definition we use. So can they fit in the 23-hour time period of discharging? So that's how we plan.
So in your practice, do you use holmium, thulium, or both?
So we only have a holmium one. So, but our standard is you can say like bipolar TURP, sorry, TURBT, and or the monopolar ones. Laser is only we use it if we specifically have a lateral wall tumor where we are really worried about the perforation. So, and it depends from person to person. So, we don't have an exact policy in our hospital, but anybody's you can select welcome to use if they want to use it. So they are available, and all theaters are equipped because we have our you can select specific theater which is equipped with laser, and the laser trained staff is always available.
And settings, what is your preferred settings for holmium laser?
Settings is quite variable. So such as when we use it, usually if we have a luminous machine, so there are already an ablation settings for these things. So which is like a low power with a higher frequency that will give you slightly best results and less power. So if your power will be higher, then what I have seen that there is a more chances that you can go slightly outside the bladder. So that's why I think it's a slightly low power with higher frequency. That's what we use.
Right. Thank you very much, Mustafa. Dr. Shan, would you like to share your slides now? So we move on to the next thing. Once you have resected your tumor, it goes to the pathologist. And what pathologist tells you is perhaps more important than what you see inside the bladder during cystoscopy in making the future decisions about surgery. So it's extremely important that we understand the pathological aspects of the diagnosis. Dr. Zishanuddin has a special interest in geopathology, and he's going to talk about what non-muscle invasive histopathological aspects are, particularly for the understanding of surgeon who he knows are very simple-minded people. Zishan, the floor is yours.
Yeah, Assalamu alaikum. Good evening, everyone. Thank you, Dr. Hamad, for the kind introduction and for this opportunity. So I'm very excited to be a part of this learning activity. So I will be giving you an overview about the non-muscle invasive urothelial cancer, the pathological aspect, and I will, in my presentation, throughout my presentation, I will give you some practical aspects, which will be helpful to you guys. So, so that's my disclosure. So just to give you an introduction about the AKU lab, this is the largest, referral lab in the country, and this is one of the first one which get the accreditation from the CAP. And we have like more than 22 histopathologists currently working in the lab. And we get like samples from all over the country, very complicated specimens. Last year, we crossed 120,000 surgical biopsies in 1 year. So it's a very busy lab. So just to tell you, like the bladder tumor, which looks like this to you guys, for me, it looks like this. And, just to tell you how many steps are taken, in the lab to, to make a H&E slide for our interpretation. Just, I will quickly go through take you through the journey. So this is the first and the most important part, for the clinicians, is that the histopathology sample collection and submission. The adequate fixation is very, very important. Like the standard fixative is the 10% buffered formalin that we use for the histopathology. And so the container should be, airtight, and it should match the size of the specimen, and the volume of the formalin should also match that. Because if the specimen is too large and the formalin is less, then the specimen which is floating above the formalin, which gets autolyzed, and which will be of no use for us. Also, the dual IDs of the patient are very important. You have to mention the name as well as a medical record number on the container as well as on the request form, just to avoid the mix-up and specimen loss. Also, the specimen coding, like which sample you are sending us in which container, like is it the bladder tumor, is it the deep muscle biopsy, is it the prostate biopsy, things like that should be clearly mentioned on the request form as well as on the container. And we need adequate relevant clinical history. For example, if you are giving us a sample of a bladder biopsy and if you are suspecting a CIS, but if you forget to mention the clinical history, it can be fairly easily overlooked by the pathologist, because CIS can be a very focal pathology, and many times it is visible only on the deeper sections. Initial sections may not reveal the pathology at all. So clinical history is mandatory. When it comes to the lab, it goes to the grossing bench. And why this grossing is important? It is mainly done for the large specimens, more important for the large specimen like this. You can't submit the entire tissue for histology. For example, if you have a radical cystectomy or radical prostatectomy, you can't submit the entire specimen. So you take representative sections. So we have trained medical officers and trainees which take sections, and they put these sections into these plastic cassettes with holes in them, so that the xylene and alcohol can penetrate and process the specimen. And once these cassettes are made, they are marked with the patient's true IDs, and then they are put in these processors overnight. We have like different kind of processors. The shortest processing time is for the renal transplant biopsy is like 5 to 6 hours. For the routine cases, we have a 12 to 16 hour processing. So once this processing is done, the tissue becomes hard, and then it is placed on a metallic mold like this, and the liquid hot paraffin is poured around it. And then this, once the plastic cassette is then pressed against this mold, and underside of when it is cooled down, this is how it looks like. The plastic cassette, it has this solidified paraffin, and you can see tissue embedded in between. And this is what we call a pathology block. So once this pathology block is ready, it goes to the microtome, and here it is. These blocks are cut into serially, and we take thin sections of the block in the water bath, and then they are taken up on the slide. These white structures are. This white structure is basically paraffin, and the tissue is somewhere in between, which is not visible at this time because it is an unstained slide. Later on, this goes to the H&E staining. So in H&E slide, we have two colors, purple and pink. The purple is, the structures which have more, nucleic acid material like nuclei, they become purple in color, while the cytoplasm, which has mitochondria in it, becomes pink in color. So we have this differential staining for interpretation. And this is the end result. We have the H&E slide with patient's ID on top, and then the end of the pathology office. This is my office on a good day. This is for, and I give the final diagnosis, and which is conveyed to the medical records. Sometimes the cases are very are challenging for us. For that we have a departmental consensus meetings for various specialty where we come up with a consensus diagnosis for a particular case. So this is the current WHO classification of the urinary and male genital tumors that we follow. It's kind of a holy book for the tumor classification. So this current edition is the fifth one, which came in 2022. Just to tell you that between the third and the fourth edition, it took 12 years, while between the fourth and fifth edition, only 6 years are there. So the things are changing more quickly, and we have more and more entities coming up because of molecular advancement. And look at the number of pages that we had in the fourth edition, only 356, and now we have a book which is very thick, 590 pages. So coming to the bladder, just to give you an overview of the normal histology by this cartoon of the bladder wall, you can see urothelium is on the luminal side, followed by the lamina propria, which is composed of loose connective tissue, blood vessels, as well as some thin muscle bundles are there, which are called muscularis mucosae. And then we have thick organoid muscle bundles called the detrusor or muscularis propria, followed by adventitia and then serosa. So just to tell you that muscle is not always there only in the muscularis propria, it is also present in the lamina propria, and these muscularis mucosae bundles can be sometimes difficult for us to distinguish from muscularis propria, because sometimes these muscularis mucosae bundles, they become hypertrophic, hyperplastic, and if the tumor is lying in between these muscle bundle, they can look like this tumor can look like a muscle invasive bladder cancer. So for muscle invasive bladder cancer, it has to be in the muscularis propria. This is the histology of the normal urothelium. It was previously referred to as transitional epithelium because it was thought it has features between glandular as well as squamous epithelium, but the urothelium is a preferred term. Sometimes there are invaginations of the urothelium in the underlying stroma, and these nests are called von Willebrand's nest. So this is a very common finding throughout the urinary tract, also in the ureter, and they can be a diagnostic pitfall for the pathologist, especially during a frozen section when we are assessing the margins of the ureter. So these von Willebrand's net can look like a tumor to an inexperienced pathologist. And when these von Willebrand's nests become more in number, they become more cystic. So we have a terminology for that. It's called cystitis cystica. And when this cystitis cystica undergoes, this glandular formation with the glandular columnar kind of lining, this is called cystitis cystica glandularis. And sometimes this acquires goblet cells in it, and therefore we use the term cystitis cystica glandularis with intestinal metaplasia. Many times there is a whole spectrum of all these lesions together. So what is this? This is not a tumor. This is a proliferative or reactive change occurring in a von Willebrand's nest secondary to chronic inflammation or irritation. And it's an extremely common finding. And I'm telling you about this because this can occasionally look like a polypoid or papillary mass on a cystoscopy. So don't get surprised if you excise something as a bladder tumor and it turns out to be cystitis cystica glandularis on histology. So this is very common in the neck, in the trigon area, and can also be seen in the ureter and medial pelvis. This is the current WHO classification 2022 that we follow in our practice. So we have urothelial tumors, we have squamous tumors, we have glandular, and then we have uncommon tumors like urachal, urethral, and Mullerian type. So I will focus on the non-invasive urothelial tumor. You can see we have first two ones, urothelial papilloma and inverted urothelial papilloma. These are the benign ones. And just to tell you that urothelial papilloma is kind of a rare diagnosis, very uncommon in my practice. Also, according to literature, is uncommon to diagnose. And inverted urothelial papilloma is relatively common, is also benign. And then we have these four malignant or malignant entities. First one is the three of them are papillary, and urothelial carcinoma in situ is a flat. So among the papillary, we have papillary urothelial neoplasm of low malignant potential. We call it PUN lump. Then we have non-invasive papillary urothelial carcinoma, low grade. And then we have non-invasive papillary urothelial carcinoma, high grade. Okay, just to share a case of a 45-year-old male who was a smoker with hematuria with atypical cells in uterine cytology, and suspicious area was biopsied. So this is a histology slide. So this is a urothelium you can see, and if you want to have a normal urothelium in comparison, you can see how disorganized the nuclei are. They are like hodgepodgely arranged. They are like pleomorphic with prominent nuclei, and there are mitosis. So compared to this is really disorganized and really atypical looking. So this is pathology that we call as carcinoma in situ, because it has not invaded the stroma. This basement membrane looks intact. So this is an in situ carcinoma. Sometimes the carcinoma in situ cells are so friable they shed in the urine, in the lumen of the bladder. Like over here, only few of them are attached to the basement membrane. So that's this property is the basis for the diagnosis of carcinoma in situ on the urine cytology, because these cells are very friable and they are shed off in the urine all the time. This is a very important diagnosis. It can clinically mimic cystitis, like interstitial cystitis, and largely a morphological diagnosis. Sometimes we do perform immunohistochemical markers like CK20, P53, and KIC7, but most of the time it's a morphology which is required for the diagnosis. And then, as I told you, urine cytology is a good tool for its diagnosis. So it's a high risk and a high grade disease, as you already know, and it carries a poor prognosis if the patient has a coexisting non-invasive papillary urothelial carcinoma. And often this CIS is a multifocal disease. Its presence is always included in the pathology report, and if you leave it alone, 50 to 75% of them ultimately will give rise to invasive cancers. The term urothelial dysplasia is not, unlike other parts of the body, like oral cavity, where if we see dysplasia, we call it a precancerous condition or CIS. Urothelial dysplasia is not equivalent to CIS. It is, in fact, a controversial term, and is avoided by most of the GU pathologists because we don't know what to do with them, how to treat them. So basically, they are those lesions which have cytological atypia, but it is not as marked as we expect in a CIS. It is short of CIS. So this is kind of a entity which pathologists use just to cover themselves, because they don't have enough features for a CIS. So for practical point of view, so if we have a dysplasia-like features in our bladder urothelium, we should think more of reactive atypia, because it has been seen by various studies that we are in fact the reactive proliferation in the urothelium secondary to chronic inflammation or instrumentation, things like that. Like it can be because of the biopsy site reaction, it can be secondary to the intravesical therapy. But still we have this term in the WHO included. Just to give you the molecular pathogenesis of the urothelial tumors, if you look at this part, in the earlier stages of the bladder cancer development, both the low grade, which is shown on the top, and the high grade pathway on the bottom. So both in the early stages, there is loss of heterozygosity of chromosome 9, short or long arm. And then in the low grade carcinoma development, there is a role of HRAS and FGFR3, as already mentioned by Dr. Nanwani. And then in the high grade pathways, where both coming from the low grade pathway as well as from the CIS, there is involvement of P53 and retinoblastoma gene. So these are the two more basic morphological patterns of urothelial cancer, the papillary type and the flat type, and both of them can give rise to invasive cancer. This is, you already know that how much is the burden of bladder cancer in the world, and it is a disease of mostly males with living in the urbanized, industrialized countries. And we all have gone through the era where the main culprit of the bladder cancer, smoking, was considered as cool and glamorous. Not anymore. And the other, risk factors other than tobacco, we have occupational exposures to aromatic amines like diesel exhaust and paint, analgesic abuse, cyclophosphamide, chronic infection like schistosomiasis, arsenic contamination of the water, and radiotherapy. So coming to the grading of the urothelial cancer, the WHO 2022 classification still recommends the same grading system that was first given by ISUP, the International Society of Urothelial Pathology, in 1997. So this is a three-tiered grading system for the non-invasive papillary tumors. So these three-tiered grading system I already shown you in the classification before. The papillary urothelial neoplasm of low malignant potential, followed by low-grade papillary urothelial carcinoma, and then we have high-grade. In the invasive group, there is no PANLAP. So we have a two-tiered grading system. So, but some geopathologists believe that once tumor invades laminar propria, it becomes high grade. But we do see cases of truly low grade urothelial cancer, papillary urothelial cancer invading the laminar propria, and rarely muscular propria, very rarely. So we still follow the same grading system recommended by WHO. So invasive tumor, large majority of them, 95%, are high grade. And just to tell you, you might already know, grading is very subjective. It has a lot of inter and intra-observer variability. And hopefully in the future, ancillary studies like immunohistochemical markers and the molecular assays may result in more subjectivity, more objectivity, and more reproducibility. So it is defined, what is grading? Like any other cancers, it is actually the degree of differentiation of the tumor, how closely the tumor resembles a normal urothelium. And these are the four features that we look for in a papillary urothelial tumor when we try to grade it. Mainly the polarity of the nuclei, which is the most important, like how orderly or they are facing the same direction. And what about the mitosis? Is it like on the basal side of the epithelium, or is it like the apex, the top of epithelium? So the higher grade tumor will show mitosis on the top of the luminal side of the epithelium more frequently. The nucleoli, once they are very frequent, it is most likely a high grade tumor. And then of course nuclear polymorphism, which means the variability and the sizes and shapes of the nuclei. So this is a papillary neoplasm, which is very thin, it's very delicate, and this is actually a papilloma. So papilloma is a rare diagnosis. I couldn't find a picture in my record, so this is a picture from the net. So this is a rare thing to see. So this has this normal urothelium, which is just thrown into papillae, and these papillae are delicate; they're not fused together, and there is no atypia at all. And once you start seeing fusion, and but still the nuclei, the thickness of the epithelium has increased now, but there is no variability in the nuclear size and shape, very orderly arrangement, and this is pun lump. And when we start seeing this kind of papillary tumor, which has some degree of nuclear hyperchromasia, polymorphism, some disarray, and you may see mitosis around the basal half of the epithelium. So this is a low-grade papillary urothelial carcinoma, non-invasive. And once you start seeing this marked polymorphism, frequent mitosis, bizarre nuclei, things are okay for a high-grade papillary urothelial cancer. But sometimes you may come across a tumor like this. Like on top of this picture, like same tumor has a very low grade monotonous cytology, and the lower part of the picture shows you a high grade morphology. So what to do with this? So this is called grade heterogeneity. So our mixed grade urothelial cancer, we do see them quite commonly. So 5 to 40% of urothelial cancer may show grade heterogeneity. So for that, you have to sample the tumor adequately. The current guideline is to submit the entire tumor and see all of the tumor before assigning a grade. So we know that they also prove that this grade heterogeneity also involves the molecular alterations like cyclin-dependent kinase 2A deletions are, they are there as an underlying cause of the high-grade development in a low-grade tumor. But also they looked at the low grade, the mixed grade urothelial cancer, and compared with the pure high grade and the pure low grade. So with this, the survival chart shows you that the mixed grade tumors, they are more close to the pure low grade ones than the high grade ones. Especially if this high grade area is very focal, they behave almost like identical to the low grade tumors. So that's the reason that now WHO has said that all the papillary tumors with the low, which are largely low grade in histology, but you have a high grade area which is more than or equal to 5% of the tumor, you can call this as high grade. And if the papillary tumor, which is otherwise low grade, but there is a focal high grade area which is less than 5% of the tumor, we just call it low grade. But we can also write this comment, which I usually avoid in my practice to avoid the confusion, that you can call it low grade papillary urothelial carcinoma with less than 5% high grade component. So this is another option. Also, sometimes grading may not be possible at all because of the poor fixation. The formalin was not adequate, was not of good quality. Also, because there might be marked diathermy, which cooks the tumor, and and we are unable to grade. In fact, sometimes it gets very difficult to diagnose a cancer at all, or because of marked diathermy in the specimen. And also, if the tumor is too scanty, too tiny, then the grading can also become challenging. So this is the high-grade papillary urothelial cancer. On the left side, this is a non-invasive one. And then we always look for whether there's laminar propria invasion or not, like this example showing the laminar propria invasion. And there are two more examples of laminar propria invasion in a high-grade papillary urothelial carcinoma. And this is a muscle invasive bladder cancer. You can see thick muscle bundles, these pink bundles, and in between you can see the tumor nests. But sometimes the pathologist cannot distinguish between muscularis mucosae versus muscularis propria invasion. Sometimes it is difficult. And most of the cases can be solved by performing additional sampling. If you haven't submitted the tumor entirely already, you go for it and we submit the entire tumor, and we may usually find a good area of muscularis propria invasion. And if you have already seen the entire tumor, deeper levels, as always, can help. Like I showed you in the pathology block has a thickness of around 5 millimeter. And if we are looking at just one section, deeper cuts, may reveal new morphology or different morphology that we see compared to what we see in the original section. Sometimes, even after the sampling and deeper cuts, it is impossible for us to distinguish between muscularis mucosae invasion versus muscularis propria invasion. Like example, this one, you can see these muscle bundles in between, which are like thin and wispy, but they are kind of prominent. So I'm not sure whether this is a hypertrophic muscularis mucosae versus muscularis propria, and you can see tumor all over around it. So in such a scenario, which is kind of uncommon in our practice, we write a note that this is a difficult case and we are unable to distinguish between muscularis mucosae versus muscularis propria, and we ask for clinical and radiological correlation. And that's how, these cases, they are discussed in the MDTs. Sometimes we have a report like this, which can be a little irritating for the urologist, where the muscle is not identified to assess invasion. So it happens uncommonly in our in-house cases, but in AQ pathology lab sees most of the workload comes from outside AQ. So these kind of reports can, cause a lot of unhappiness in the urology camp. And we do get calls from the urologists outside AQ mostly, inquiring about the whereabouts of the muscle, and we have to tell them when that's left in the patient, because this is the actual reason. In many cases, muscle is not sampled by the surgeon, and we know that this is technically challenging and requires expertise. But sometimes the tumor itself is so extensive that it eats up the entire muscle. and it gets very difficult, impossible for the pathologist to tell. And that's where we ask for clinical and radiological correlation. Sometimes pathologist doesn't sample the muscle, like it was sent by the urologist, but the pathologist didn't follow the protocols. Like they are supposed to submit the entire tissue, but some labs, like small labs, private labs, they try to save money and they make only a few blocks, and the muscle may be left in the specimen in the container. So in that case, always ask for the pathologist to entirely submit the tissue, and also if they have submitted the tissue entirely already, ask for deeper cuts. For the same reason, the deeper cuts may reveal muscle. And lastly, there may be interpretation error from the pathologist, especially if they are not experienced. This is just quickly, the staging system that we follow. And just to tell you that this micropapillary pattern, we are very familiar with, it's an aggressive subtype of the urothelial cancer. But just to inform you that this micropapillary pattern also exists in the non-invasive tumors. But luckily, they don't behave differently. They behave like the usual high-grade papillary urothelial cancer, low-grade, high-grade ones, non-invasive ones. So that's why WHO recommends this micropapillary term only for the invasive cancers, just to avoid confusion. So this micropapillary is only for the invasive cancers. So the urine cytology, Dr. Nandwani talked about it. So we use a PAUS system. It can be a good tool, but the sensitivity for the low-grade ones is kind of low. The only scenario where we can confidently diagnose a low-grade urothelial neoplasm if we see a well-formed papilla in the urine, which is kind of a rare thing to see. So with this, I finish. This is nothing to do with the urology. This is chondrocytes in the epiphyseal plate. So these histology images, sometimes they look really pretty in the microscope, and sometimes I do use them as a wallpaper. So with this, I thank you. Any questions?
Thank you very much, Ishan. I think you have very comprehensively covered very basic aspects of pathology and also talked about the various pathological, how to interpret a pathology report. It's extremely important that we have a to and fro discussion between clinicians and pathologists, because that really changes. And we have noticed that since there is a closer interaction in our institution between pathology and the clinicians, it sorts out a lot of issues. So thank you very much. There's just one question which has not been addressed. The rest is mostly addressed about nephrogenic adenoma and cystitis cystica. They're both benign conditions. A few words about these two conditions?
Yeah, both of them are reactive processes, and cystitis cystica is something which clinically also looks like a tumor, but this nephrogenic adenoma or nephrogenic metaplasia can be a nightmare for the pathologist. I have seen many cases like which were misdiagnosed as cancer on a referral case. So yeah, this is a reactive condition, and it can be easily diagnosed under experienced hand, but it can be a huge diagnostic pitfall.
Any words about your experience so far between en bloc resection? I don't think that you get in our clinical notes whether it's an en bloc resection or is it a piecemeal resection.
Yeah, we don't usually. There was one study done by one of your residents, Mohib, I guess, Mohibullah, some years ago. So
Yes.
that was the only time I used to get some cases which were unblocked, but they were a little difficult for me to, because orientation is very difficult, there is some degree of fragmentation in the specimen. So, or to tell anatomical orientation was a little difficult for me to assess. But I used to look at the diathermy, artifact as the margin, just which helps me, in interpreting those cases. Yeah.
One last question is from Johar, and he wishes to know if there is a regional variation in detrusor muscle thickness and depth.
For us, like there is some kind of if this detrusor muscle can be more close to the urothelium, like it is more thickened in the areas of trigone as compared to the other parts. So whenever we have a sample which is labeled as a trigone area, and we have like muscle very close to the urothelium, so we always keep in mind that this is normally close to the urothelium in this part compared to the other parts of the bladder.
Thank you very much, Ishan. We move on to the next presentation, and we're very lucky to have Professor Mitsogiannis, Professor of Urology in Athens, Greece. Dr. Mitsogiannis is going to talk about follow-up. Now, we know that once you've made the diagnosis, you've started off the initial treatment, it's extremely important that you keep an eye on these tumors because they have a propensity for both recurrence and progression. There have been recent changes in our protocols of follow-up. EAU is now recommending less vigorous follow-up, and all these aspects will be taken up by Professor Mitsogiannis and his presentation on the follow-up of NMI urothelial cancers.
Well, thank you very much, Professor Khan, for the kind invitation. I'm glad to participate in this very interesting webinar. I'm sorry, I have to share the...
Yeah, we can see your slides now.
Yeah.
Perfect.
Right. Yeah. Well, as I was saying, we're going to discuss a few things about the follow-up in these patients in non-muscle invasive bladder cancer. First of all, I'd like to mention a few things about some data about bladder cancer, if I may. It is the 10th most common cancer worldwide, and it is a male. The age standardized incidence rate is multiplied by 4 in the male versus the female, and also the age standardized mortality rate is 4 times more in the male again. Now, fortunately, 75% of cases, as we know, are confined to the mucosa or submucosa. So they are TA, T1 or CIS disease. But as we all know, this group of cases of patients is characterized by substantial heterogeneity because we don't treat the same way a TA bladder cancer and a CIS bladder cancer, as we all know that. Now, it was mentioned previously some of the risk factors, of course, tobacco smoking and occupational exposure to carcinogens like aromatic amines, arsenic, environmental exposure, and other things like external beam radiation to the pelvis. All these risk factors may influence the presence of the cancer. And also some things about the transrectal resection, which is the essential first step in the management of the bladder cancer. And we do have plenty of techniques nowadays. It was, again, mentioned before. We have the traditional piecemeal resection in fractions and the DN block technique using either the bipolar or monopolar diathermy or the thulium or holmium YAG lasers. We should take cold cap biopsies if we have an abnormal looking urothelium, and also prostatic urethra biopsies when indicated. And of course, the detrusor muscle should be present in the specimen. Otherwise, a second TURBT should be carried out, which is the case also in incomplete resection of the tumor. In the high-grade tumors or the T1 tumors, as we all know that. I'm not going through in details on all of these calculators and things like that, but I just want to mention that there are plenty of diagnostic tools, if I may say, in the internet, like the URTC calculator, to assess the probability of recurrence or progression at 1 or 5 years. Now, every patient should be categorized in one of these 4 groups. The EAU non-muscle invasive bladder cancer risk groups. We know we have the low risk group, which usually contains the small lesions which are low grade and less than 3 centimeters in diameter. These tumors have a very low density to progress. There is an intermediate risk group which contains it's rather peculiar because it contains all the cases that cannot be categorized in one of the other groups. And of course, we have the high risk and the very high risk group with the high grade tumors, G3 tumors, some of the G2, the old G2 tumors, which are T1, and of course the CIS. I think it's important for us to try and categorize the patients one of these 4 groups, because this has a very we can categorize them to assess the prognosis. Following the TURBT, one may put the patient in an active surveillance. Active surveillance should be the patient should be followed if they have a TA low-grade tumor. These tumors have practically 0 propensity to progress and low likelihood to recur. Of course, we do have recurrences, but these are, generally speaking, the good, between quotation marks, tumors that will not usually cause any severe problems. Of course, there are tumors that need adjuvant treatment, either intravesical chemotherapy or intravesical immunotherapy. I think it's beyond the scope of this talk to get through this in details. But we have to say that the first cystoscopy, which is carried out at 3 months' time after the operation, is very important. It should be carried out in all patients, and it is a prognostic indicator for recurrence and progression, because if you have a tumor that recurs during that period, then it possesses an ominous, if I may say so, prognosis. And the frequency of subsequent cystoscopies depend on the risk of patients for recurrence and progression. That's why, like I said previously, it's very important for us to categorize patients according to their risk. What about the duration of follow-up? In the low-risk group, the follow-up, is stopped 5 years after the initial of the follow-up. In the intermediate risk group, it lasts for 10 years, but in the high-risk and very high-risk group, patients should be followed throughout their lives. And we can see here a table from the guidelines of the European Association of Urology. We can see here that in the low-risk group, no cytology should be carried out, and the patient should have a cystoscopy at 3 months, a second cystoscopy at 12 months, and then annually for a period of 5 years with no need for upper urinary tract imaging like CT, for instance, or CT urography. In the intermediate group, again, no cytology is needed for follow-up. The frequency of cystoscopies is higher. We have a cystoscopy at 3 months, and then every 6 months for 2 years, and then annually for a period of 10 years. And again, no systemic imaging is mandatory. In the very high risk group, cytology is mandatory, because cytology urine cytology usually detects a high-grade disease. Cystoscopy is carried out every 3 months for 2 years, and then every 6 months for 5 years, and then annually throughout the patient's life. And there is a need for CT, according to the guidelines, every year for 5 years, and then every 2 years for 10 years. So this is a very strict, we might say, schedule that the guideline, the EAU recommends, but we have to take under consideration that the strength rating for this is weak. This is a reason that for some because some urologists do not really follow that as they should. So the strength rating is weak. A question that really has been discussed throughout all these years is whether cystoscopy is the only way to go in the follow-up during the follow-up period, and whether this diagnostic modality can be replaced by another one, less invasive, let's say. So we do have adjunct measures nowadays. We have ways for enhanced tumor visualization, like the blue light flexible cystoscopy. The ultrasound scan of the bladder is not considered to be a very reliable tool for the follow-up, because some of the tumors cannot be detected on an ultrasound scan. The same goes for a urinary cytology, because it's not reliable in low-grade tumors. And also we have molecular markers. I'll try to go through the data for the first and the fourth of these measures. Now, first of all, the blue light cystoscopy is generally considered to be a useful tool. Of course, the results of various prospective studies are a little bit contradictory, because we have 2 studies that show that there's a benefit of the blue light cystoscopy, and another one that this modality is not beneficial. This is a study that was conducted in the US. Prospective study included 322 patients with CA, T1, CIS, and even T2 disease. Most of the tumors were high grade, 61%. In patients who had a normal white light cystoscopy and an abnormal blue light cystoscopy, there were 26 cases of this, 80%. Of these 26 cases with abnormal blue light cystoscopy, 15 cases were biopsied, and the detection rate was 87%, as expected. So if the white light is normal and the blue light is abnormal, the detection rate increases substantially. And also, if both of these cystoscopies are abnormal, this was the case in 83 cases. Of these 83 cases, 27 had lesions that were only seen on blue light flexible cystoscopy. So this study was concluded that the use of blue light cystoscopy in the follow-up period really improves surveillance and also performance of office-based biopsy. Another study that showed benefit of the blue light cystoscopy is this one, which is again from the US. Patients from this registry that had intracycle BCG treatment were included in this study. And the aim was to calculate the percentage of cystoscopies with recurrences that were missed with white light alone. So there were 282 cystoscopies with an overall recurrence rate of about 45%, which was substantial. 6% of these cystoscopies, in 6% of these cystoscopies, recurrences was detected only on blue light cystoscopy. 88% were CIS cases. So overall, 13% of recurrences would have been missed without using the blue light technique. And also there was a 5% false positive rate for the blue light cystoscopy. It means that there were some lesions detected on blue light, but a subsequent biopsy did not reveal any cancer whatsoever. So the authors concluded that it is a useful tool, and also that healthcare providers should consider blue light cystoscopy, at least for high-risk patients who are on BCG treatment and are followed extensively. There was another study that was conducted again, I think, in the US. In this study, which was a randomized controlled trial, there were two groups during the follow-up period. In one group, a flexible white light cystoscopy was carried out, and at the second time, a second look, a narrow band imaging cystoscopy in the first group, and the second group, again, a white light cystoscopy, and at the same time, a second look, a white light cystoscopy. So what they found was that there was no difference in the recurrence rate between these two groups. The second look cystoscopy revealed 57 additional lesions, and the number that were revealed with a narrow band imaging was significantly more than that, than the other group. But in cases with no initial detection, the per patient improvement by the second look cystoscopy was very small. So in cases that there was no detection of tumor during the first cystoscopy, the second cystoscopy, either with a narrow band imaging or the white light, did not reveal a substantial number of recurrences. Also, the second look cystoscopy did not influence the detection of CIS, and the authors concluded that despite having significant benefits, the narrow band imaging, which was checked in this study, did not prove to increase per patient tumor detection in this setting. So we have contradictory results. If I may say, my feeling is that this is a modality that may help towards a proper diagnosis and may be used as an adjunct measure. On the other hand, we have some urinary molecular markers that have been in the market for long. Of course, we have to say in the beginning that the ideal marker does not exist, because the ideal marker should have nearly 100% specificity, sensitivity, whatever, and also detect a low-grade disease, which is not the case nowadays. The older markers had very low sensitivity and low-grade disease, but we have some novel markers that reportedly have improved sensitivity and substantial negative predictive value. We can see here some of these markers that really try to target some of the mRNAs that are expressed in blood or DNA methylation biomarkers, so on and so forth. So we can see here the table from the guidelines, and we can see that the sensitivity varies from 0.5 to 0.992%. And the specificity again is substantially these more recent tests have higher sensitivity and specificity, and all of them have a substantial and impressive, let's say, negative predictive value. There is a meta-analysis, systematic review meta-analysis in the literature. I think it was conducted a couple of years ago. It included 21 studies with nearly more than 7,000 patients. Most studies had a risk of bias. This is mentioned in the paper. And we can see here the sensitivities, specificities, positive and negative predictive values, 93%, 84%, 67%, and 99%, respectively. So in this systematic review and meta-analysis, the novel markers were found to be efficacious in reducing cystoscopies. It was mentioned that excuse me, up to 740 cystoscopies should be avoided in 1,000 patients. the quality of life and the cost effectiveness need, as they mentioned, further investigation. But they conclude that for these biomarkers, urinary biomarkers, molecular markers, there is a promising role in the future. Now, all these, either the blue-eyed cystoscopy and the novel markers are very useful adjunct measures, but can they really replace the follow-up cystoscopy? So the guidelines say that there's no urinary marker nowadays that can replace cystoscopy during the follow-up period and should not be used in a routine fashion. This is from the EAU guidelines, and also the AUA guidelines say that clinicians should not use urinary biomarkers in replacement of cystoscopic evaluation of patients. So I think we're not in the level that we should replace cystoscopy with something less invasive. Another issue is the adherence to follow-up cystoscopy. There are plenty of papers in the literature looking at that. The adherence to follow-up cystoscopy is about, I think it's about 80%. There are studies, for instance, this study reporting that the non-adherence, not adherence to the follow-up protocol, may have some severe impact on the patient. For instance, this study, which is retrospective and included nearly 200 patients with TA or T1 high-grade disease or CIS, looked at the adherence and non-adherence to the protocol. The adherence rate was about 82%. So 36 patients did not follow the protocol properly. The recurrence rate was similar. The cancer-specific mortality rate was similar, but the progression rate differ significantly between the two groups. So it was 33% in the non-adherence versus 18% in the adherence rate. So the authors concluded that it was a hazard ratio about 2.3. There are also some other studies indicating the same, and also that the recurrence rate is also influenced, but by the non-adherence to the strict protocol. And we can see here the estimated survival for patients in the adherence and non-adherence group. So in conclusion, non-muscle invasive bladder cancer is generally considered to be a controllable disease, provided a strict adherence to the protocol is followed. The patients should be well informed about this need, and this is a very important factor as well. Cystoscopy still remains the main diagnostic tool in the follow-up setting. And of course, what we can say now for the novel urinary markers is that they are promising and may have a role in the future as adjunct measures in the follow-up schedule. But it's very unlikely that they will ever, according to the current data, replace cystoscopy as the main diagnostic tool in the follow-up period. Thank you very much.
Thank you very much, Iraklis. I think that's a very comprehensive presentation in which not only you have emphasized the regularity in the follow-up, and as we now very clearly seen from these three presentations, that management of non-muscle invasive bladder cancer is a team effort. With the pathologist identifying the disease, we are able to make the right sample of the tissue as a surgeon, and then follow-up is extremely important. And it is only by this team effort that you can achieve the best possible result in the management of this difficult and expensive disease. So a few final words from our three speakers. I will ask Mustafa first that what one additional modality, if one can afford, would you recommend based upon the contemporary literature?
Can I?
Yeah, you go first. Yeah. Mm-hmm.
Yeah, based on the data, I think one of the already extensively investigated tool is the blue light flexible cystoscopy. Despite the fact that some of the papers did not really opt for this, I think it is important that at some stage we should use them. I mean, the procedure, the blue light flexible cystoscopy, just to identify some of the suspicious areas which are indicative of recurrence. The markers, I think we were far away from putting them in the daily practice.
Okay. So I think from my point, I think the modality-wise, yes, I have used some of the PDD, the blue light cystoscopy. The challenges what I was facing, because particularly in the NHS system, when you are running your list, because it takes time to, you can say, like deliver some substance in the bladder and then leave it for 1 or 2 hours and then do the flexible cystoscopy, and then there is some cost. And actually the amount of, you can say, like gain we are getting after the blue light cystoscopy, you can say, like I may be wrong, but I think it's not that significant. But I think if we'll do the more and more, the more, you can say, like benefits we will get. The number one, because nowadays I think it's an oral substitutes, we can use it. I don't know what's the progress about it, but these have been used particularly in Japan. Secondly, what I find when I have not used too much, but this like narrowband imaging, because as an application, it seems like more easily and feasible because it's already a part of camera systems where you just simply turn on the button and then it changes the wavelength and then it gives you slightly different view. So that's slightly ease. And third system, I think what I have seen, it's not studied well, but I think if you see in the stack system, there are some filterings like I'm not sure, this is something like an S images or something that's already built in the digitalized images, so that can help you in detection of tumors. So I think these two are slightly simpler, and PDD is there, but I think it depends which center you are working, what's your feasibility and how much number of staffings you have it. So, but it does not mean that by using this, you should not do a normal meticulous standard cystoscopy. So it's not an alternative to normal standard cystoscopy. That's.
Thank you, Mustafa. Zishan, any final words about how would you like the specimen and what clinical information would be really helpful when you are writing your report?
Yeah. So as you mentioned, if we have the relevant clinical history, like if there any history, is this a primary tumor or is a recurrent tumor? That's very important. What's the grade of the previous tumor? And as someone have mentioned about the nephrogenic metaplasia. So if we have a history of a urothelial tumor and this is some suspicious area on a follow-up, this should be kept in our mind. And also about the grading, grading, as I've already mentioned, it is very subjective. And it is good to have GU expertise in your institute. So developing a consensus on a difficult case, is very important.
Right, great. Thank you very much. I think we have very comprehensively covered non-muscle invasive bladder cancer, modalities of diagnosis, pathology, and the follow-up. Next session is on the treatment, intravesical treatment, and we're going to take up intravesical chemo, intravesical BCG, and what to do in the BCG refractory cases. So 3 interesting presentations coming up in the next session. So until then, thank you very much. And I'm really grateful to Mustafa Nanwani from Scotland, Dr. Zishanuddin from Karachi Khan University, and Professor Iraklis Metsiogiannis from Athens, Greece, for their valuable time and for wonderful talks. So have a very good evening and a very good weekend. Thank you very much, and goodbye.
Good evening, thanks.
Thank you.
Thank you very
Thank
much.
you.
Good evening.
Thank
Good
you.
evening. Bye bye.
Thank you.